Hello everyone, my name is Ana Maria Vale. Today I'll be presenting a case study on post-traumatic stress disorder, or PTSD. This case will demonstrate how we identify, assess, and manage PTSD in primary care settings. My patient is a 34-year-old female Army veteran who presents with the chief complaint. I am having constant nightmares and feel on edge all the time. I can't sleep and loud noises make me panic. Before we discuss her case further, let's review what PTSD is. Post-traumatic stress disorder is a psychiatric condition that occurs in people who have experienced or witnessed a traumatic event, such as combat, sexual assault, natural disasters, or serious accidents. The pathophysiology involves dysfunction of the HPA axis, leading to altered cortisol section, hyperactivity of the amygdala, causing an exacerbated fear response, and reduces prefrontal cortex activity, which limits emotional regulation. Neurotransmitters changes also occur, specifically increased norepinephrine and decreased serotonin, which contributes to hyperarousal, mood changes, and intrusive symptoms. History of present illness. Her symptoms began 6 months ago after returning from deployment. They occur daily and include nightmares, flashbacks, hypervigilance, and avoidance of social situations. Loud noises and crowds worsen her symptoms, while quiet environments and grounding techniques help. She is currently taking sertraline and prazosin, but she is not yet in therapy. Current medications. Her current medications are sertraline 100 milligrams daily for mood stabilization, prazosin 5 milligrams at bedtime for nightmares, and occasional melatonin for sleep. She has one documented allergy to penicillin, which causes a rash and facial swelling. Her medical history includes generalized anxiety disorder and mild asthma. She is divorced, lives alone, and works part-time. Her mother has depression and her father has hypertension. Her review of symptoms reflects her chief complaint. She has fatigue, insomnia, palpitations, stress-related nausea, muscle tension, headaches, and PTSD symptoms including nightmares, flashbacks, and emotional withdrawal. On exam, she is anxious but alert and cooperative. Cardiopulmonary and neurological exams are normal. Her mood is anxious, but she demonstrates good insight. I use the PHQ-9 to assess depression and the PCL-5 to confirm PTSD symptoms per DSM-5. Her scores confirmed significant psychological distress. CBC, CMP, and TSH were normal, ruling out systematic and endocrine causes. A negative urine drug screen ruled out substance-induced anxiety or depression. PTSD is the primary diagnosis because she meets DSM-5 criteria with trauma exposure, re-experiencing, avoidance, and hyperarousal lasting over 1 month. Depression is possible, but secondary. GAD is less likely because her anxiety is trauma-specific. Adjustment disorder doesn't fit due to the chronicity and severity. Panic disorders is unlikely because she doesn't have recurrent, unexpected panic attacks. The plan is to continue the patient with the current medication, refer the patient to trauma-focused cognitive behavioral therapy and eye movement desensitization and reprocessing therapy, and teach sleep hygiene and grounding techniques. Follow-up will be in 2 weeks, then monthly. I provided the patient with contact information for 5 community resources that offer PTSD-specific support, counseling, and crisis intervention. please find all the 5 centers below in my slide.